What's up, everyone? It's Miles here from bootcamp.com, and today in pulmonology, we're going to be going over asthma. So in this video, we're mostly going to be going over the asthma disease process, diagnoses, and associated conditions, and in the next video, we're going to be going over asthma treatments. So before we jump into asthma, let's just review some airway basics. So recall that airways can either constrict or dilate, and the three main mediators that you want to know for bronchoconstriction are histamine, leukotrienes, and acetylcholine binds to muscarinic receptors. And there's two main mediators that you want to know for bronchodilation. The first one is norepinephrine that binds to beta-2 adrenergic receptors in the airways. The second one, if we just blow up a cell here, is CAMP or CAMP that acts within the cell. Furthermore, if we look at the bottom of the screen here, we can see that we have parasympathetics for acetylcholine. This is because parasympathetic activation leads to acetylcholine release with subsequent bronchoconstriction. And similarly, we have sympathetics for norepinephrine, and that's because sympathetic activation leads to norepinephrine release and subsequent bronchodilation. And so if we take a look at the text here, the three main mediators of bronchoconstriction are histamine, leukotrienes, and parasympathetics in the form of acetylcholine binding to muscarinic receptors, and the two main mediators of bronchodilation are going to be sympathetics in the form of epinephrine binding to beta-2 adrenergic receptors, as well as CAMP or CAMP within the cell. Now let's talk about some asthma basics. So what's mainly going on in asthma is that there's airway hyperresponsiveness, and the hyperresponsiveness of the airways is going to result in episodic and reversible bronchoconstriction. And it's really high yield to note that asthma is episodic and also reversible. And we're going to see in the video on asthma treatments that we can acutely reverse asthma by administering beta-2 agonists. So during an episode, some of the symptoms that we can see are going to be wheezing, and wheezing is especially high yield, especially for boards questions. They often give you wheezing in asthma questions, and recall that wheezing is an expiratory sound heard as air goes through narrowed or constricted airways. Some other things that we're going to see are coughing, dyspnea, and hypoxemia. And the hypoxemia makes sense because if we can't get air and we can't get oxygen into the lungs, that means we can't get oxygen into the blood, and so we're going to have low partial pressures of oxygen in the blood, or in other words, we're going to have hypoxemia. So just going back to the important note that asthma is episodic, this means that between episodes, patients are going to be asymptomatic, and that's important to remember, and we'll be talking about that more in just a minute when we get to diagnosis. Okay, now let's talk about the different types of asthma, or the asthma subtypes. So the first asthma that we're going to talk about is atopic or extrinsic asthma, and this is kind of the classic asthma that everyone thinks about when they think of asthma. And this type of asthma is caused by a type 1 hypersensitivity reaction, or in other words, it's IgE mediated, and we'll be talking more about this in detail in just a minute. And as the name suggests, extrinsic asthma, this asthma is due to the airways reacting against an extrinsic antigen or an allergen that's coming in from outside of the body, and so there's going to be an identifiable allergen. So atopic asthma usually has a childhood onset, and it's usually initiated by classic triggers such as pets, dust, and pollen, and usually these patients will also have a history of atopic dermatitis and allergic rhinitis. There's a classic triad called the atopic triad. It consists of atopic asthma, atopic dermatitis, and allergic rhinitis, and these three usually go together, especially in boards questions. The next type of asthma is called non-atopic or extrinsic asthma. So as the name suggests, this is due to an intrinsic problem with the airways themselves. The airways aren't reacting against some extrinsic antigen, so there's going to be no identifiable allergen, and this usually occurs following things like viral infection, stress, or exercise. Next, there is status asthmaticus. So status asthmaticus is acute severe asthma, and this episode of asthma is usually unremitting, so it's not stopping, and due to this it could possibly be fatal. And a classic setup for status asthmaticus is someone has asthma for a long time, and then all of a sudden they go into status asthmaticus, which is a really severe bad episode of asthma that's unremitting. And lastly, there is NSAID induced asthma. So if we just recall the arachidonic acid pathways here, we have arachidonic acid, which can go through the COX pathway to make prostaglandins, or it can go through the LOX pathway to make leukotrienes. And what NSAIDs do is they block the COX pathway, and by blocking the COX pathway, this is going to increase the flux of arachidonic acid through the LOX pathway, and as a result, we're going to get increased production of leukotrienes. So when NSAIDs block the COX pathway, this is going to result in increased production of leukotrienes through the LOX pathway. And recall at the beginning of the video that we said that leukotrienes was one of the mediators for bronchoconstriction, and so this could precipitate an asthmatic episode. And obviously not everyone who takes NSAIDs has episodes of asthma. You usually have to be a genetically susceptible individual to get NSAID-induced asthma, and interestingly, these patients can also have nasal polyps in adulthood, and this is in contrast to conditions like cystic fibrosis, where we see nasal polyps in a child. And furthermore, commonly, individuals who have NSAID-induced asthma will also have chronic rhinosinusitis. Okay, now we're going to talk about atopic asthma pathophysiology, and we're first going to use a diagram to illustrate this. So the pathophysiology of atopic asthma is broken down into two separate events. The first event is called initial exposure or sensitization, and this is when we have the extrinsic allergen or antigen enter into the airways for the first time. Here, the allergen is picked up by an antigen presenting cell and then presented to a Th2 helper cell. The Th2 cell is then going to do two things. The first thing is it's going to produce IL-4 and IL-13, which are going to stimulate plasma cells to start producing IgE antibodies towards the foreign antigen. The Fc portion of the IgE antibodies, if we just draw out an antibody here, the Fc portion is then going to bind to mast cells. And when mast cells have IgE antibodies bound to them, we call the mast cell primed. The second thing that the Th2 cell is going to do is produce IL-5, which is going to cause eosinophil recruitment. Okay, the second event in the pathophysiology of atopic asthma is called repeat exposure or reaction. This is when we encounter the foreign antigen for a second time, except this time, now we have all these eosinophils and primed mast cells lying around. So what's going to happen now is the allergen is going to bind to the IgE antibodies on the mast cell and cause them to cross-link. This cross-linking of the IgE antibodies is going to cause the mast cell to degranulate. These degranulation products are going to give rise to an early or immediate phase reaction, as well as a late phase reaction that occurs hours later. The main degranulation products that mast cells release are histamine and leukotrienes, and recall from the beginning of the video that we said these were two mediators involved in bronchoconstriction, and that's what's really occurring in the early phase is bronchoconstriction. In the late phase, or hours later, the histamine and leukotrienes are going to result in vasodilation and eosinophil recruitment. And the eosinophils are going to squeeze out of nearby blood vessels and enter into the airways, and there they're going to release something called major basic protein, and you can kind of think of major basic protein as the main weapon of eosinophils. And the release of major basic protein from the eosinophils is going to result in inflammation and mucus production, which is really what's occurring in the late phase. Okay, so now just circling back to the text, the first event in the pathophysiology of atopic asthma was called sensitization. Here, a foreign antigen enters the airways for the first time, and Th2 cells are going to be presented with that antigen by antigen-presenting cells, and then the Th2 cells are going to respond by doing two things. One, they're going to produce IL-5, which is going to cause eosinophil recruitment. Secondly, they're going to produce IL-4 and IL-13, which is going to stimulate plasma cells to produce IgE antibodies towards that foreign antigen, and then those IgE antibodies are going to bind to mast cells, and then we call those mast cells primed. The second event was called repeat exposure. Here we encounter the foreign antigen for a second time, and now the antigen is going to bind to IgE antibodies on those primed mast cells. When it binds to the IgE antibodies, it's going to cause them to cross-link, which is going to activate the degranulation of the mast cells, and two of the main degranulation products were histamine and leukotrienes. In the early phase, the histamine and the leukotrienes caused bronchoconstriction, whereas in the late phase, the histamine and leukotrienes are going to cause vasodilation and eosinophil recruitment, and the eosinophils are then going to squeeze out of those vasodilated vessels into the airways, where they're going to release major basic protein, which is going to cause inflammation and mucus production. Okay, Now we're going to go over the diagnosis of asthma. So recall that asthma is episodic, so usually these individuals will have a normal exam when they're asymptomatic between episodes. So one of the ways that we diagnose asthma is by inducing an episode in the doctor's office and then taking spirometry measurements. And one of the ways that we induce an episode is by doing something called a methacholine challenge. Methacholine is a cholinomimetic, and so it's like acetylcholine, and therefore it'll cause bronchoconstriction, especially in a patient that has airway hyperresponsiveness. If the patient has asthma and there's a large degree of bronchoconstriction, then the spirometry measurements will start to reflect that of an obstructive lung disease, so we'll start to see a decrease in the FEV1 to FVC ratio. Furthermore, we can also start to see a decrease in the inspiration to expiration ratio. Usually we spend about twice as long expiring as we do inspiring. However, during an episode of asthma, we might be spending 4 times as much time expiring as we do inspiring. Okay, and next we'll talk about some of the pathological sputum findings that we can see in asthma. So first we're going to see elevated levels of eosinophils, and this makes sense because as we mentioned in the pathophysiology, we have a lot of eosinophil recruitment to the airways. Next, we can see something called Charcot-Leyden crystals, and these are essentially crystal structures made of eosinophil granules. And lastly, we can see Kirschmann spirals, which are described as whorled mucus plugs with epithelial casts, and these are a result of the mucus production and the inflammation that occurs in the airways with damage and sloughing off of the epithelium. So if we just take a look at these histology images here, we can see these crystal structures. These are called Charcot-Leyden crystals, and they're basically made of eosinophil products. And in the bottom picture, we can see these spirally black figures. These are Kirschmann spirals, and they're made of mucus plugs with epithelial casts. Okay, and lastly, we'll talk about a few conditions that are associated with asthma. So the first two we already spoke about as part of that atopic triad along with atopic asthma, and they were atopic dermatitis and allergic rhinitis. The next associated condition is something called allergic bronchopulmonary aspergillosis, or ABPA, and this is a hypersensitivity reaction in the airways towards antigens on the Aspergillus fungus. And classically, this condition occurs in asthmatic patients or cystic fibrosis patients for 2 reasons. The first reason is that the Aspergillus spores tend to get stuck in the thick mucus that's present in the airways of these patients. And secondly, individuals with asthma or cystic fibrosis are susceptible to producing large quantities of IgE and IgG antibodies towards Aspergillus antigens. So classically, when we diagnose this condition, we're going to see high levels of IgE, eosinophilia, and a positive IgG Aspergillus serology. And some of the symptoms that we typically see in ABPA are going to be similar to an episode of asthma, so we can see things like airway inflammation, wheezing, and mucus plugging. And lastly, if the patient has recurrent exacerbations of ABPA, we can start to see things like pulmonary infiltrates, which are little opacities seen on imaging, and in this case, the opacities are usually due to mucus plugging with microatelectasis. And furthermore, we can also see bronchiectasis. Okay, so I just wanted to finish up the video by reminding you not to get allergic bronchopulmonary aspergillosis confused with the other pulmonary conditions that aspergillus can cause. So number 1, as we just discussed, allergic bronchopulmonary aspergillosis is usually seen in patients that have either asthma or cystic fibrosis. And secondly, there's something called an aspergilloma, which is essentially a big fungus ball, a big ball of Aspergillus fungus in the lungs, and this usually occurs in patients that have prior cavitations in the lungs, such as patients that had previous tuberculosis infection. And lastly, there's something called invasive pulmonary aspergillosis, which is a widespread Aspergillus infection, and this is usually only seen in patients that are immunocompromised. All right, and that's all we got for our video on asthma.